I'm so happy to be able to introduce you all to the Infection Detective, which is a remote patient monitoring system for surgical incisions at home. And I'm here today representing our Longhorn Life Sciences team. We're an experienced multidisciplinary team. We've been working very effectively together the last 2 years. We are working together with Miles, James, and Nick Schneider, who are our collaborators from UT Austin with background in physics, engineering, mechanical engineering, and business. I work together with Scott Alpard, who's an entrepreneur and our department administrator here at MD Anderson in breast surgical oncology. And I'm Cristina Checka. I'm an associate professor of breast surgical oncology here in Houston, and I'm the innovation officer for our department. Together, Scott and I, working with other collaborators in our department, have 2 other devices and 3 apps, all undergoing current stages of prototyping. The problem that our team identified is that a certain percentage of patients will experience an infection after elective operation. And we basically instruct patients, hey, give us a call if you notice that this is happening. But this requires, number 1, that patients correctly identify the problem, and number 2, that they effectively communicate that back to their team. Risk factors for these infections, which we are all familiar with, are unfortunately on the rise. This includes obesity, smoking, and diabetes. And the stakes can be high, especially for our cancer patients. They may subsequently have delay in cancer-related treatments and have worse outcomes. As well, hospitals can be financially penalized. The pain point is illustrated here. This is one of my patients. She noted this skin change, but she didn't report it to us. So this is how she looked at her scheduled post-operative visit. Not only did she have redness, but by this time she also had fever and malaise and required hospitalization for IV antibiotics. And it made us think, hey, what if we could have detected this infection at home? So our team came up with the following clinical needs statement. And we've been very fortunate to gain some preclinical insights. We have visited with about 75 patients, clinicians from various roles, and from other surgical departments beyond my own, as well as other departments such as infectious diseases, and stakeholders and decision makers. And basically what we learned is that often patients can't necessarily see their own incisions. This is true if there's an incision on the back, in the groin, or here in this example, my patient couldn't actually look at her own drain site, and they're often not entirely confident that they are okay based on what they're seeing. We also learned that surgical site infections can pretty much happen anytime before or after a scheduled postoperative visit. And the peak incidence of this is between 7 and 14 days after elective surgery. As we scope back a little bit and examine the breadth of the problem, worldwide, there's more than 300 million major operations being performed. 40 to 50 million of these are in the US. And of these patients, 5 to 15% will require rehospitalization within that first 30 days. And a significant proportion of these are surgical site infection related. The burden is great. Surgical site infections and the concomitant cost of treatment cost our healthcare system more than $3 billion annually. The average cost for each individual patient hospitalization is about $21,000. Therefore, our solution is an invention that we have called the Infection Detective. This is a layered wound management system. I'll take you one by one through the layers. First, we have a porous polylactic acid microneedle scaffold. This is a scanning electron micrograph showing the side view of one of these microneedles, and this represents work performed in the lab last summer trying to perfect the design. Next, there is a microfluidic passive flow system, which is basically a patterned microchannel that draws via capillary action and capillary pump interstitial fluid into the system. And this is followed by a sensor array. This will detect changes in electrochemical features such as pH and temperature. And I'll draw your attention to the fact that the sensor is powered by induction and requires no onboard battery. The reason why our solution works is the incisional milieu itself. As we all know, the normal process of healing after an operation is a process of inflammation. However, surgical site infections are largely caused by the bacteria that colonize the skin surface, and therein derive changes along the spectrum of pH and temperature. The wound environment goes from a more acidic to a more basic environment, and the temperature becomes more warm. And concomitantly, this precedes the cardinal sign of infection, which is the redness that a patient may see on her skin. Our competitive landscape includes two basic categories. One are the current standard option being used daily in a worldwide fashion, and other competitor products that we've grouped together as a smart bandage type of category. It's tremendously exciting to be developing this invention right now with this competitive landscape. The current standard, to say it in plain English, is simply to provide a waterproof, sterile cover directly on the incision. And these smart bandages are distinguished from our product in two major ways. Number one, although many of them provide some features of what we are interested in, which is detecting surgical site infection, detecting objective data, none provides the profile of features that ours does. And most interestingly and importantly, all of these devices are being developed and intended for chronic open wounds, which is very different from our device. Now, these would be used, two examples would be diabetic non-healing wounds and venous stasis ulcers. We think that there may even be potential for these to be complementary technologies of sort, because certainly these open chronic wounds didn't start life out that way. Our competitive advantages include, of course, the ability for clinical teams to be able to make a decision to start oral antibiotics early and shift that expensive inpatient care of infections to the less expensive outpatient setting. We'll be able to thus reduce readmissions, increase throughput, and we see a huge potential for the objective data acquisition. We're most excited about this. We'll be able to generate big data in aggregate that will allow us to compare perhaps hospital to hospital, even hospital systems within a city like my own in Houston, and even different regions of the country. We also see downstream the potential for increased patient compliance and patient engagement, which we hope lead to higher patient satisfaction scores. Our commercialization timeline is as such. We incorporated 2 summers ago. We've since put our idea through several accelerator programs and pitch competitions and have been able to gather some early prototype funding via grant awards that we've won. And this spring, we filed our provisional patent. However, we're most excited for the road ahead. We intend to raise now our funding that will allow us to complete our prototyping, move forward with animal and human testing, and our goal is to be able to go to the market at the conclusion of 2025 with a product at the market. We plan to use our funding in 2 parallel pathways. Number one is the physical development of our prototype. We're actually working with the computer engineering folks at UT Austin. We're trying to use benchtop validation testing through their help in building computational simulations to figure out the best design. We need to know the exact number of microneedles per square centimeter of our wound management system that will best allow our product to work. We also want to de-risk our technology by first applying our device in ex vivo porcine skin. For that, we have several options, not only at my own institution in Houston, there are other facilities right next door here in the Texas Medical Center, and of course in UT Austin. In parallel, we'll be working with the computer engineering folks to work on signal processing software encoding, and we hope that this big data that we generate objectively from patients at home can then have machine learning algorithms applied to it. Our financial projections are as follows. We are seeking $2 million of seed funding in this year to cover these development costs. I'll draw your attention to one cost that we see as important a little further down the road that will make our product attractive and competitive, which is to be able to integrate with the electronic health record. Before I sign off, I'd like to extend our heartfelt thanks and gratitude, particularly and specifically to Mr. Wayne Embry, who's been my Equalize mentor. And we offer 3 ways that you can help us. Number 1, we'd love to hear your perspective if you've been a patient or caregiver. Please help us identify any potential collaborators. And we would love to take a call or meeting with you to discuss funding. So I thank you for your time.